Sir, for the introduction, and thank you, Manu sir, for accepting the invitation to chair the session. Indulka sir is actually my UG time teacher. I am UG pass out from SS Medical College Diva. So when I was in final MBBS, he was my teacher. So thank you, Indulka sir, for chairing the session. And to start with, my topic for today's talk is endocrine disruptors, or commonly known as endocrine disrupting chemicals. So in the next 20 minutes, I will be talking about the burden of endocrine disrupting chemicals, the different definitions put forward by different societies like WHO and Endocrine Society, and the major historical landmarks about the EDCs evolution, and the different sources of EDCs, the characteristics and mechanism of action of different EDCs, and I'll be discussing some important EDCs as there are thousands of EDCs in the environment. So it is not possible for this 20 minutes lecture to discuss them in detail. So to start with the EDC's burden. So 73 billion pounds of chemicals, they are imported or produced in the US each day. And most people, including newborns and infants, have nearly 100 different chemicals that can be measured at any point of time. So 80,000 industrial chemicals, including around 3,000 chemicals produce more than 1 million pounds per year, are not being measured in the environment. So there are different definitions put forward by. So WHO has put forward this definition. It is for the regulating purpose only, and EDCs as an exogenous substance or mixture that alters the functions of endocrine system and consequently causes adverse effects in an intact organism or its progeny or subpopulations. Now, Endocrine Society has again redefined it, and it is for a biological perspective, for a clinical perspective, for a clinician's use. It defined as an exogenous chemical or mixture of chemicals that interferes with the hormone action. So what are the different historical landmarks in evolution of EDC research? In 1962, a book was published by Rachel Carson known as Silent Spring. The book was about the DDT and exposure to the environment, and there were many thousands of birds, they are dying from the exposure to DDT. So the Rachel Carlson, she has compiled all the information related to that and published a book known as Silent Spring. So it was this Silent Spring book publication which led to a worldwide outcry and led to a ban on the DDT use in USA in 1972. However, DDT is still used in some parts of the world, including India. In 1971, the dust catastrophe, I will be discussing this in the next slide. And in 1991, the term endocrine disruptor, it was finally introduced. And WHO issued first global assessment of the state of science of EDCs in 2002. Ubisugen word was coined in 2006. And in 2009, Endocrine Society issued the position statement on EDCs. And in 2015, the introduction of the term metabolic disrupting chemicals was done. So what was dust catastrophe? For 30 years, from 1940 to 1971, the pregnant ladies were given Diethylstilbestrol to give pregnant ladies to prevent the maternal complications. And it was later found that the daughter of these mothers, they have future increased risk of adenocarcinoma of vagina, which is a rare carcinoma before the age of 30 years. And there are other also issues were also there, like infertility, spontaneous abortion, and preterm delivery. And it was also observed that death sons, they have increased risk of testicle cancer and other reproductive dysfunctions. So where these endocrine disrupting chemicals are coming from? First, they are coming from the dioxins, from the industrial waste. They may come from phthalates, from the toys. They may come from the flame retardants like fire extinguisher, phenols from the industrial waste, polychlorinated biphenyls like electronic waste, pesticides like used in farming, polyaromatic hydrocarbons used in oils, spillage of oils in the seas, and phytoestrogens from the environment. So this is how we are exposed to EDCs. The mechanism of action of EDCs and their exposure. So the oral consumption of EDCs, it may come from the industrial waste or leaching of chemicals from the containers of the food. And the common EDCs are PCBs or BPAs or phthalates. Contact with the skin, it may have household, it may come from household furniture, or pesticides use, and DDT and chlorpyrifos are the major EDCs. Intravenous exposure can be from the intravenous tubings, for example, phthalates. Application to skin, it can be iatrogenic, for example, antibacterial medications or medications, and some cosmetic use. So common EDCs in that content is phthalates, cycloxane, or parabens. And EDCs can also be transmitted from biological transfer, vertical transfer from the placenta, or it can be excreted into the mother's milk. So numerous EDs can cross the placenta and excreted in the milk. And these are the different categories and common examples of EDC, like pesticide, they contain DDT and chlorpyrifos. Children products, they contain lead and phthalates. Food contact materials, they contain BPA phthalates. Electronic products, they contain polychlorinated biphenyls. Personal care products, they may contain phthalates. Antibacterials, that may contain cycloxane. Textile clothing, that may contain perfluorochemicals. So what are the different characteristics of EDCs? The EDC exposure, it can have a lag time. So the patient may be exposed to EDC at any point of the time, and the expression of disease may be at any time in future. So there is a lag time. There are different critical window periods, and the patient may be exposed at the fetal life, infancy, puberty, or pregnancy, and the disease expression may be in the later life or at the adulthood. They have got the lower affinity for hormone receptors. For example, bisphenol A, it has got the 10,000 times lower affinity for estrogen receptors than commonly 17 beta estradiol. And cause-effect association, as I've already mentioned, we are at a time 100 types of different EDCs can be measured in a human body. So there are different cocktails of EDCs, and they interact into an addictive or synergistic way. And EDC displays a non-monotonic U-shaped biphasic curve. As the Professor Frederick said, that there are no such things as safe levels when you are talking about endocrine disruptors. So a few words about the mechanism of action of EDCs. EDCs may alter the hormone synthesis and secretion. So it may act at the gland level. EDCs may alter the conjugation of binding proteins, binding to carrier proteins. So it may act at the transport level. And EDCs may alter the response at target tissue. And modifying the receptor or competing for the receptor, or alter the hormone metabolism. So EDCs can act at any point of hormones, any point from the hormone synthesis, transport to action. So what are the clinical presentations at multiple levels? EDCs, when they are exposed to mother and fetus in utero, they may cause SGA and IUGR, or disruption of endocrine metabolic formant known as fetal origin of adult disease. EDCs in the childhood, it may cause obesity, changes in metabolism, pubertal variations, and thyroid dysfunctions. EDCs, when exposed to adulthood, they may cause fertility, infertility, obesity, changes in metabolism, and thyroid dysfunction, and finally carcinogenesis. So what are the heritable, what is epigenetics? Now we are going into detail of mechanism of action, just a single slide. Heritable alterations in the gene expression without any structural change in the DNA sequence, which can be transmitted through mitosis or meiosis. So this is chromosome, chromatin, and DNA. So epigenetics work at methyl group. The methyl group can tag DNA and activate or repress the gene. It goes to the histones, and epigenetic factor is attached to the histone tail, thereby causing histone modification. And the final endpoints would be the cancer, autoimmune disease, or mental disorders. Now coming on to some important EDCs. So first of it is DDT. So this is an organochlorine pesticide, and I've already discussed about this silent spring. And India is still using this DDT in some parts. It is an estrogenic mimic. It has action on early puberty, early menarche, or late menopause. It has also got anti-androgen action, causing cryptopyrin and testicular dysgenesis syndrome. From where we are exposed? We are exposed from animal fats, milk, meat, fish, or eggs. Second important EDC is bisphenol A. It has got estrogenic properties. It has got also anti-androgenic properties, blocks at the receptor level. It causes dysmetabolism, decreases POMC fiber density, increases agouti-related peptide and neuropeptide Y. So this is how bisphenol A works. So this is the chemical structure of bisphenol A, and BPA is found in 93% of Americans, and we are commonly exposed from the plastic products, epoxy resins and DVT. It got bioaccumulation and aquatic food chain, and ingestion is through ingestion, inhalation, and dermal exposure. BPA incorporates into the cell membrane, and there are multiple targeted mechanisms like activation of cytochrome P, binding with estrogen receptor, DNA methylation, histone changes via epigenetics, and the various health impact factors from right from the prostate cancer, infertility, pubertal delay, cancer, and diabetes. Now, here is an interesting study, a study of urinary bisphenol A level in the endocrine disorders. It was conducted by Dr. Anupam Kumar under the guidance of my professor, Dr. N.K. Agrawal sir, and I was also a part of this published work. So the study of urinary bisphenol A levels in endocrine disorders. We measured urinary BPA levels in different endocrine disorders, for example, type 2 diabetes, primary hypothyroidism, PCOS, non-obstructive azoospermia, and simple obesity, and approximately 30 patients each were taken, and control population was also 30. So we measured urinary BPA level in each. So less than 500 urinary BPA levels is considered normal. More than 500 is considered abnormal. So 500 to 1000 is found in some patients, and you can see that more than 1000 picogram per mg of urinary BPA is found in approximately more than 50 to 70% of this population. So this study concluded that Indian population is exposed to bisphenol A, very high level of bisphenol A, and the values of bisphenol A in urine was very widely distributed, showing the variability of exposure. And the test was significant differences were obtained in the median values of BPA between the cases of azoospermia, PCOS, and obesity. Now, this is another article saying that decrease in anogenital distance among the male infants with prenatal phthalate exposure. So what is anogenital distance? One line about the anogenital distance. It is the distance referred from the distance from the anus to the external genitalia. In the female, it is measured from the center part of the anus to anterior part of the clitoral surface. And in boys, it is measured from the center part of the anus to the anterior part of the base of the penis. So this study, anogenital distance as a marker of androgen exposure, it shows that shorter anogenital distance is associated with low sperm concentration, count, motility, and overall hypogonadal state. So this study said that compared the anogenital distance and penile length in cryptorchid and hypospadias patients. So you can see that mean standard deviation in cryptorchid and anogenital distance in hypospadias is very less. So the characteristics of boys with complete physical examination. This study compared the anogenital distance in normal population as well as the boys whose mother's prenatal urine was assessed for phthalate metabolism. So you can see that anogenital distance, the mean anogenital distance in the normal population is 70.3 millimeter, whereas it is 70.3 millimeter, whereas it is decreased in prenatal exposure of phthalates. It is 68. So 50th percentile is 70 versus 68. So in a study population, anogenital distance is grossly reduced. Now, a few words about the secular trends. Examination of US puberty timing data from the 1940 to 1994 for the secular trends. And it has also been speculated that endocrine disrupting chemicals that are potential contributors to the observed shifting of puberty time. The puberty time is shifting towards at an early age. So this is the panel consensus about the evidence of secular trends. So there is the sufficient data that said that girls' breast development onset is a little earlier, as well as girls' menarche is a little earlier occurring from the previously. And there are insufficient data for the boys' puberty development. So here is the graph showing the age at menarche. So this graph clearly shows that age at menarche in 1840 to 1860, it was around 15 to 16 years. So 15 to 16 years was the mean age of menarche in 1860s, whereas it has gradually coming down to 1960 to 1980. So at present, we are having girls with age at menarche around 12.5 to 13 years. This again is in the similar graph showing the secular trend in age and menarche according to the first year of data collection. So you can see that age at menarche is approximately 17 years in 1850s, whereas it has gradually coming down to approximately 13 years in 1990 and 2010. Whereas in last 50 years, the age at menarche is almost static. This again showing the secular changes in age at onset of breast development. So age at onset of breast development is also coming down from 11 years to 10.5 years approximately. And the pubertal onset in boys, it is also going down. And previously, the testicular enlargement occurs at 12 years approximately. Now it is at 11.5 to 11 years. So this is the graph showing the recent changes in male puberty time. In 1985, the male puberty time, average male puberty time was approximately 12 years, and it is gradually shifting towards a lower time, and approximately at mean age is 10.5 to 11 years of the male pubertal time. So now another article, age at menarche and tenor stage in girls exposed in utero and postnatal to polydominated biphenyls. So in this, age at menarche in daughters who are exposed in utero to PBBs. So those girls who are not breastfed, they have the mean age of menarche at 12.7 years. And those girls who are breastfed with the contaminated milk with polydominated biphenyls, they have mean age at menarche at 11.6 years. You can see the 95 confidence interval with 0.9 and 2.5. So the mean age at menarche of exposed girls, it is less than 1 year. Is the difference is 1 year less. And the same study, the onset of pubic hair development. So those girls who are not breastfed, they have odd ratios and 95% confidence interval is 0.6. And there's a significant difference in those who are breastfed, approximately 8.4. So there is, so this study showed that girls exposed to polydominated biphenyls have early onset of pubic hair development as well as menarche. Another study, association of phthalates, parabens, and phenols found in personal care products with puberty timing in girls and boys. So this study was said that high maternal urine level of triclosan was associated with early menarche in daughters, and high level of maternal urine levels of phthalates, they are associated with early pubic hair development. Similarly, the girls exposed with high level of parabens, they have early breast and pubic hair development. So where this chemical is coming from? Triclosan, it is used as an antibacterial agent. Phenol is used in pesticides. This phenol is used as in toilet deodorizers. Phthalate is used as personal care products, and parabens used in cosmetics. So there is early age of onset of puberty in menarche when patients are exposed to phthalates, parabens, and phenols. Few words about the endosulfan. This is organoclothing insecticides. So the humanity is exposed by the aerial swine, and there were mass deaths and deformities reported in animals. So it has got multiple actions. It has endogenous disruptor in males, causing delayed puberty in clitoris, and overall causing hypogonadal state. So one study about this, the effect of endosulfan on male reproductive development. So you can see that this is the study population. This is the SMR for pubic hair development. This black line is control, and yellow and blue line is for study population. So you can see the development of pubic hair and age at aerial exposure of endosulfan. So you can see the control population had the pubertal onset of this time, and those who are exposed to endosulfan has the delayed onset of pubic hair development. Similarly, the delayed onset of testicular development. Similarly, the delayed onset of penile enlargement. So overall, endosulfan has got the effect of dilation delayed in the puberty. A few words about the obesity and obesogens. So exposure to obesogens during the development can produce an altered standpoint. So where these obesogens are coming from? These are conventional endocrine disrupting chemicals like thibutylin, phthalates, parabens, phytoestrogens. In 2015, pharma consensus give the hypothesis of metabolic disruptor hypothesis, and according to that, fat obesogens are there. So environmental chemicals that can act during development and or other sensitive time periods according to the lifespan to control adipose tissue, and by altering food intake and metabolism via specific effects on brain, pancreas, adipose tissue, liver, GIT, muscles, individually or in the combination. And in some cases, there could be a second hit, for example, high calorie diet and stressful lifestyle. So what metabolic disruptor hypothesis says that we all know that the traditional risk factors for obesity and metabolic syndrome is increased energy intake and decreased physical activity. Along with this, there are novel risk factors like endocrine disruptors So they combinedly act on the hypothalamus, liver, adipose tissue, skeletal muscle, pancreas, and these novel markers, for example, EDCs, they act on the composition and or optimal function of GI microbiota and exert immunomodulatory properties. And this combined action causes a coordinated attack toward the multiple critical components, causing obesity, metabolic syndrome, diabetes, and NFLD. So what are the clinical perspective? What clinicians should learn from these EDCs? So we can prevent, yes, we can try to prevent it. Always take the environmental history whenever you are dealing with the patient, especially when dealing with the pregnant and pregnant ladies and children. Diet, yes, we should start using the diet low in animal fats and prefer using organic foods. Consumer practices, we can change the consumer practices. For example, we can use PVC products for neonatal ICUs and vacuum with HEPA filters. So now, next two slides. Conclusion and guidance for the clinicals. So we say that human population is chronically exposed to a large number of industrial chemicals, and each of us possesses approximately 100 unique EDCs circulating in our body at any point of time. So what a clinician should know and what a patient should be advised. There are simple steps which patients can take and clinicians can advise to their patients, that avoid fast food and processed food, avoid junk foods, limit food that are high in animal fat, overall saying that avoid non-veg diet, and limit fish that are known to contain PCBs and mercury. Do not microwave food products in the plastic containers. Always watch for the ingredients commonly used in the households, like cosmetics, ingredients in the cosmetics and skincare products. Don't use pesticides at home, kitchen, and over your surroundings. Keep your home free from dust that contain lead and pesticides. And pick plastics carefully. Always see that the plastic you are picking, the water bottles, the children water bottles, they should be BPA free. Always use water-based paints, use digital thermometer, avoid mercury thermometer, and eat organics and fresh products whenever possible. Thank you.